gut or the large intestine, it starts from the cecum. We know cecum is a saccular structure. Already we have idea about the cecum. It is present in the its location is the right iliac fossa, within the right iliac fossa, and it is related to the anterior abdominal wall anteriorly, and coils of small intestine. When cecum is empty and from the cecum we see the commencement of the large gut, and this part we know that is the ascending colon, and the next part, this is the transverse colon, and there is a flexure which is called the right colic flexure, which is in relation to the liver. So it is called, we know there is a colic impression of the, which is present in the undersurface of the liver, actually which is been created by this right colic flexure, and we can imagine there is a liver, and from here this part of the large gut, it is oriented horizontally or transversely, so that part is called the transverse colon. Now we know what are the cardinal features of the large gut. Number one, the tenia coli. What is tenia coli? Tenia coli is there are localized aggregation of the longitudinal muscles. There are localized band of longitudinal muscles. In the gastrointestinal tract, we actually get 4 layers. Generally, we get 4 layers from outside to inside. We know that is the outside, that is the serous or peritoneal layer, then muscular layer, then submucous layer, and most inside there is mucosal layer. So that muscular layer has got outer longitudinal muscle and inner circular muscle, and this outer longitudinal muscle is aggregated in some place or condensed in some places, and it gives rise to formation of linear band which are known as tenia coli. There are 3 tenia. One is called tenia libera, next is tenia mesocolica, and tenia ommentalis. Tenia libera is, we can find this linear line. This is the tenia libera, and on medial side and the lateral side we get tenia mesocolica and tenia ommentalis. 3 bands of muscular fiber, longitudinal muscular fibers. So that is one of the important feature. Next feature is, you can see there are several sacculations, which is very important, or haustrations. Sacculations or haustrations, because the length of the tenia coli is shorter than the length of the whole gut, the length of the large gut. The length of the large gut is more than the length of this tenia coli. As a whole, there are formation of several sacculations. So the second cardinal feature is circulations. And third important feature of the large gut is you can see some peritoneal pockets filled with fat. They are called appendices epiploicae. So there are three cardinal features, but these, and we can expect this cardinal feature throughout the large intestine or the large gut, except in rectum and anal canal. In rectum and anal canal, we cannot find these features. And also, we know that it's the another vestigial organ, that is vermiform appendix, where we will not get all these features. So these features are absent in vermiform appendix, and also they are absent in the তোমাকে বলছি, I have already mentioned, I have already given you the clue. একটু জোরে, আমি শুনতে পাচ্ছি না, তোমরা বলো না স্যার, একটু জোরে বলুন। এই বলো, কাছে এসে বলো, আমার কানে কানে এসে বলো। In which part of the large gut these cardinal features are absent? তা শুনতে পাওনি না, তোমার মনটা এদিকে নেই। আমি দেখি, মন দেখে আমি রিড করি সবাইকে, আমি ঠিক তোমাকেই ধরলাম, আমি ওকে ধরিনি। তাহলে এদিকে মনটা দাও, দুদিন পরই তো পরীক্ষা, হাবুডুবু খাবে তখন, যাও ওখানে। So again I am repeating, these features are absent in appendix and they are absent in the rectum and anal canal. Now the large gut has several parts, which starts with the cecum and appendix, and then the part which is ascending, which is known as the ascending colon. Then we get a flexure, which is continued as the transverse colon. Again, this transverse colon ultimately makes a flexure, and it is continued below. As you can see, this is the descending colon. Then it is continued as a S-shaped colon, which is called the pelvic colon or the sigmoid colon, and from the third piece of sacrum, it is continued as the rectum and anal canal. So, with the ascending colon, what is the feature, most important feature? Ascending colon is fixed to the posterior abdominal wall. It is retroperitoneal structure, whereas the transverse colon is hanging. It is hanging with the help of a peritoneal fold, which is called the transverse mesocolon. We can find the peritoneal layer here around the cecum, peritoneal layer around the appendix. So this appendix is movable, whereas the ascending colon is fixed. It is fixed or plastered to the posterior abdominal wall. Now you can here we can find there are some peritoneal folds. This is terminal ileum and this is the appendix, and this is the junction between the small gut and the large gut, and here we will get the ileocecal valve, and here one peritoneal fold above and one peritoneal fold below. This is called superior ileocecal fold, and this is inferior ileocecal fold. And recess formed by these folds is called the superior and inferior ileocecal recesses. This inferior ileocecal recess, you can see the superior one contains so many blood vessels, but the inferior one, in the inferior one there is no blood vessel. That area is called bloodless area of Trebs, inferior ileocecal fold, on the inferior ileocecal recess which is formed by this inferior ileocecal fold. So that is called the Trebs recess, bloodless area. So we can find an area behind the cecum, that is retrocecal area, that is retrocecal recess. Okay, and similar recesses are present in connection with the duodenum, supraduodenal recess, infraduodenal recess, paraduodenal recess. Just correlate with this one. Next. Well, already we know the blood supply, that is the large gut is a part of the mid gut and also a part of the hind gut. The junction between mid gut and the hind gut is the transverse colon. Right two-thirds belongs to the mid gut and left 1/3 belongs to the hind gut. That is the junction. So up to that area, the blood supply is contributed by the superior mesenteric artery. The branches of the superior mesenteric artery like middle colic, right colic, and ileocolic, and you know that ileocolic branch supplies the cecum and the appendix. Okay. Next. Already about the ileocecal orifices we have discussed yesterday. Okay. These are all covered yesterday. So this is what we are getting. The ascending colon, this is the junction between the ascending colon and the transverse colon, and this is the junction between the transverse colon and the descending colon. So this area is called the right colic flexure and this is the left colic flexure. Right colic flexure is in relation to the liver. Due to the pressure effect of the liver, right colic flexure is at lower level, whereas it is in relation to the spleen. We know the colic impression of the spleen, we have seen. So it is at a higher level. So what is the position of right and left colic flexure? We know the transpyloric plane. If I place my hand over just below the xiphoid process, and below that area if I draw a line, that is called the transpyloric plane. So the right colic flexure is 1 inch below this transpyloric plane and 4 inch away from the midline. Whereas the left colic flexure is Similar, 1 inch above this transpyloric plane and 4 inch away from the midline. So this is the position, the surface marking of the right and left colic flexures. Now this transverse colon is hanging from the posterior abdominal wall with the help of a peritoneal fold. Similarly, this part is also hanging from the posterior abdominal wall. There is a peritoneal fold. And these peritoneal folds are called, in case of transverse colon, transverse mesocolon. Similarly, a peritoneal fold by which this sigmoid colon is hanging from the posterior abdominal wall, that is called sigmoid mesocolon. That is called sigmoid mesocolon. Okay. So what I was saying, that is the transverse mesocolon. Okay. Actually, there is a fold of peritoneum which is hanging from the stomach, which is called greater omentum. It has got 2 layers. These 2 layers folded upon itself and ultimately covers this transverse colon, and it forms the transverse mesocolon. Okay. So within the transverse mesocolon, what we can find, there is anastomosis between, we know there is a middle colic artery. This middle colic artery divides into right and left branches. We have seen the middle colic artery divides into right and left branches, and these branches moves along this fold of peritoneum or the mesocolon. So we can find the anastomosis between the right and left middle colic arteries. And also on this side we are getting left colic artery and sigmoidal arteries. So there is a junction, this is the junction between the midgut and the hindgut. Right 2/3 belongs to the midgut and left 1/3 belongs to the hindgut. From here onwards, the whole gut is called the hindgut, which is being supplied by inferior mesenteric artery. And here we know the inferior mesenteric artery gives left colic branch, and here it is giving the sigmoidal artery, and ultimately continued as the inferior mesenteric artery is continued as superior rectal artery. So there is within the transverse mesocolon we can also get, there is one branch, that is the right branch of the left colic artery. And also within that mesocolon we will get several lymphatics. We can get the mesenteric fats. Okay, so we can expect all these things. So transverse colon and transverse mesocolon. What is transverse mesocolon? Mesocolon means peritoneal fold. When it is hanging with the help of the peritoneal fold, okay, from the posterior abdominal wall, that peritoneal fold is called mesocolon, and within the mesocolon we can get several arteries, fats and lymphatics. Also we can expect the nerves, that is, it is a visceral nerves, that means autonomic nerves. Autonomic means sympathetic and parasympathetic. Sympathetic is contributed by the thoracic splanchnic nerve, which actually within the when it enters into the abdomen, it forms the celiac plexus, superior mesenteric plexus and inferior mesenteric plexus. So all these nerves will supply this organ. So we can expect these nerves within this mesocolon. And the parasympathetic is contributed by the vagus. And this vagus is here, the vagus will supply up to this junction, up to right two-third. Up to the right two-third of the transverse mesocolon, it is supplied by the vagus. From left one-third onwards, it is being supplied by parasympathetic nerves, but they are coming from, parasympathetic is called craniosacral outflow. That means sacral nerves. S2, S3, S4, or they are called the pelvic splanchnic nerves. So, from this part onwards, the supply is from the pelvic splanchnic nerve. The root value is S2, S3 and S4. Okay, along these sacral nerves, the parasympathetic nerves will move and supply this area. Okay. So left colic flexure, we know this is in relation to the, it is in relation to the spleen. Very good. And we have seen from, suppose there is spleen, you can imagine there is a spleen. It is present in the left hypochondrium. Right colic flexure is present in the right hypochondrium, whereas the left colic flexure is present in the left hypochondrium. And here we are getting the spleen. We can imagine. And we can also imagine this spleen from here, one peritoneal fold can come up and it can go up to the diaphragm. We can imagine there is a diaphragm, and from here a fold of peritoneum will move from here to the diaphragm. Already we know that is phrenico-colic ligament, suspending ligament. One is suspensory ligament, linophrenic, and another is suspending ligament. Okay, so the left colic flexure. Okay, from there onwards, we will get, this is the descending colon. What is the length of the transverse mesocolon? What is the length of the transverse colon? 50 centimeters. Length of the pelvic colon is almost next to it, that is 40 centimeters. And it is variable. And length of the ascending colon 15, and this is double, that is around 30. So around this descending colon we can get some area. I have told you that ascending colon and descending colon, they are fixed to the posterior abdominal wall. You cannot move. But along the right side and left side of the left side of the ascending colon, or right side or left side of the descending colon, you can get some area, peritoneal pocket. They are called paracolic gutter. These paracolic gutters are important. There are also some peritoneal gutters and peritoneal sacs like hepatorenal pouch of Morrison. Okay, and this paracolic gutter, they are very important. And similarly in the lower part, rectovesical pouch, rectouterine pouch, these are peritoneal folds, because these areas, if there is a collection of pus or any material, it can percolate through this area around the paracolic gutter, and ultimately it can settle down over the rectovaginal pouch or recto-uterine pouch in case of male, and rectovaginal pouch in case of female. Okay, so remember there are some paracolic gutter around the ascending and descending colon. Okay. Now about the sigmoid colon and sigmoid, we can see this is a S-shaped. One is descending part, one is horizontal part, and again the next descending part. So it forms an S. So it is called sigmoid colon. Similarly, this we can get a sigmoid mesocolon that is peritoneal fold, which is triangular in shape. In a triangle we can see an apex. Here we can also see an apex. The sigmoid mesocolon is triangular. From here we can draw one line. Here we can form a triangle, and this is the sigmoid mesocolon. What is the apex of the sigmoid mesocolon is in relation to the left ureter. The kidney, from the kidney, the ureter is coming down. So, at the apex of the sigmoid mesocolon, we can find the ureter. So, again, the blood supply already you know. Again, it is repeating. And what is the marginal artery of Drummond? Actually, it is being supplied by, suppose this is right colic, the middle colic, right colic, ileocolic, from here left colic. So they are giving branches, and around the margin, we are getting a continuous arterial supply, one straight artery around this margin. So that is called the marginal artery of Drummond. Suppose the right colic artery is blocked. It can happen in mesenteric. Suppose there is an embolism, there is one clot is formed in the right colic artery. So right colic artery is blocked. So we can expect that that part of the gut will not get any blood supply. No. Because there is a continuous arterial supply at the margin, which is being contributed by middle colic, ileocolic. So that is the marginal artery of the Drummond. Actually, it is being contributed by all these arteries. Hey, rectum anal canal. Darao, rectum anal canal. Get fistula, you will get hemorrhoids, piles. So, unless and until you have some idea about the rectum and anal canal, you cannot understand. Actually, the rectum actually starts. Actually, the sigmoid colon is continued as rectum from a third piece of the sacrum. From the third piece of sacrum, the sigmoid colon is continued as the rectum. And this rectum is continued as anal canal from, we know this is the tip of the coccyx, ½ inch below and 1 inch in front of the tip of the coccyx. The rectum actually forms a loop and it is continued as anal canal. So the gut is continued as ascending colon, transverse colon, descending colon, sigmoid colon. Then sigmoid colon is continued as rectum from the third piece of the sacrum, and it ends 1 inch below, a half inch below and 1 inch in front of the tip of the coccyx, and we get a sharp turn which is called the perineal fold and is continued as anal canal. So rectum is 12 centimeter in length, whereas anal canal is 3.8 centimeters. That means 38 millimeters. So you can expect this is the rectum. It is continued and it is in relation from, you can see, first piece, second piece, from the third, fourth, fifth. So from third, fourth, fifth piece of the sacrum and the coccyx, it is continued. Okay, and half inch below and 1 inch in front, there is a sharp turn. It is continued as the anal canal. So this is rectum and this part is the anal canal. And you can see what is the relation. Behind we are getting the sacrum. We are getting the sacrum. In front, in case of male, you can find urinary bladder. It is related to urinary bladder. And below the urinary bladder, we can get this gland. This is the prostate gland. And we can get this as seminal vesicles. So we can get all these things. That means the urinary bladder, prostate, seminal vesicles, vas deferens, all are in anterior relation to the rectum. So rectal examination is carried out. When it is carried out, if we suspect a prostatomegaly, we can perform a rectal examination and we can feel anteriorly, we can feel the prostate gland if there is a prostate, benign enlargement of the prostate, which is very, very common. In old age, it is very common. In your family, one or two members in your family might be suffering from this disease, very painful disease. They cannot hold the urine. There is an urgency and frequency. So, unless and until you know the rectum, the anatomy of the rectum, you cannot, and unless and until you know the surrounding anatomy, that is the relation, you will miss many things as a clinician. So, this is rectum and behind it is related to the sacrum. And in front of the sacrum, what are the structures you can imagine? There is one muscle, that is piriformis muscle. We can see coccygeus muscle. We can see in the middle, that is a one artery, median sacral artery. You can remember oil structures, obturator nerve, iliolumbar artery, lumbosacral trunk, sympathetic plexus. Omit O, that means obturator nerve. All these things, that means iliolumbar artery, lumbosacral trunk, sympathetic chain on either side, and in the midline you will get the median sacral arteries, and also you can expect some lymph nodes. So they are in relation. Now, there are there are some curvatures. Actually, one curvature which is contributed by the sacrum is sacral curvature. It is resting over the sacrum, so sacral curvature. Then it is making a turn at the tip of the coccyx, so which is called the perineal curvature. It is remaining like this. Then it is folded like this. Okay, so that is the perineal curvature. From here, from the tip of the coccyx, it folds backwards to be continued as anal canal. So there are two curvatures, sacral curvature and perineal curvature. And there is these curvatures, sacral curvature and perineal curvature, we can see anteroposteriorly. And if we see it from the front, we can see some lateral curvature. 1, 2, 3. One curvature on the right side, then one curvature on the left side, then again another curvature on the right side. So these are called the lateral curvatures. Okay, so these are the curvatures. And the middle, we can see there is enlargement which is called rectal ampulla, which forms the rectal ampulla. The whole rectum is covered by a loose areolar tissue sheath. Loose areolar tissues which forms a sheath around it, which is called the Walder's sheath. Nature has purposefully made this sheath very loose and lax, because what is the function of the rectum? It's a reservoir of fecal matters. So there is an ampulla, rectal ampulla, there is a sheath around it which is loose and lax. Okay. Now within here you can see the peritoneal relation. Only upper part, actually, if we divide the rectum into upper 1/3, middle 1/3 and lower 1/3, only the upper 1/3 is wrapped with peritoneum on all sides. The middle 1/3 is wrapped with peritoneum just on the front side, and lower 1/3 does not have any peritoneal covering. Okay. Now the peritoneum, this is showing all this structure. There is median sacral artery, iliolumbar arteries, sympathetic trunk and everything. Now within the rectum we can find these are some folds. These are called some rectal valves or Haustra's valve. We can find the first valve in the upper part, which is very much consistent, which we can get it. And this fold is related to the left wall of the rectum. The next one is very much consistent. Always we will get the second one. And this second one, actually sometimes actually the fold it forms a sphincter, is continuous, continuously it is all present all around the walls, and it acts as a sphincter which is called Nilaton sphincter. Okay, Nilaton sphincter. Another fold we can get, the third fold, it is on the left wall. So it is around 2.5 centimeter below the second fold. And sometimes we can get another fourth fold just from here, which is around 2.5 centimeter above the second fold, which is called fourth fold. Now, what is the importance of the second fold? Second fold is very important, which is called the Nilaton sphincter. Because it holds the feces, fecal matter. This part of the rectum remains empty, and this part remains loaded with the fecal matters. So if we injure this second fold or Nilaton sphincter, what will happen? There will be rectal incontinence, urinary incontinence, fecal incontinence. So you will know later on in the lithotomy position, we always pass a cannula when we are performing a rectal douche or enema, when we are inserting a cannula, we always try to negotiate through the left lateral position, not through the right lateral position. Because if we negotiate that cannula through the right lateral position, it can affect this Nilaton sphincter. Okay, so these are the rectal valves or Hauston's valves, which very commonly when I come in your final MBA examination. Okay, Nilaton sphincters, the rectal folds. About the arterial supply, you can see it is supplied by the superior, middle and inferior rectal arteries. Superior rectal artery is nothing but the continuation of inferior mesenteric artery. Middle colic artery is a branch from the internal iliac, anterior division of the internal iliac, and the inferior colic, it is inferior rectal artery, which is a branch from the definitely anterior division of the internal iliac, but not directly, it is coming from the internal pudendal artery. So it is being supplied by all these arteries, rectum and anal canal, they are being supplied by this. Now about now this is the vein. Superior rectal vein, middle rectal vein and inferior rectal vein. Superior rectal vein is ultimately continued as inferior mesenteric vein, which drains in the splenic vein. Splenic vein joins with the superior mesenteric vein and ultimately forms the portal vein. So the superior rectal vein is nothing but part of the portal circulation, whereas the inferior rectal, middle and inferior rectal vein, they are systemic veins. So there is a connection between the systemic veins and the portal vein. or portocaval. Caval means vena caval. Junction. And the junction is here. Okay. This is called the dentate line, like you can see of the anal canal. This part above this is supplied by this superior rectal vein, and below is by the inferior rectal vein, and also by the middle rectal vein. So if there is portal hypertension, what will happen? These channels will get dilated. If there is an obstruction in the superior rectal vein, so there will be backflow of the blood, and it will create the channels, and it will create, actually dilate the channels, and at one time there will be rectal bleeding. Similarly, there will be esophageal bleeding. There is connection between that is the azygous system of veins, and also by the left gastric vein, which is the portal vein, the part of the portal vein. So there is a esophageal development of esophageal varices and bleeding. So these are some sites. So this is the site where we can get, at least remember, portocaval anastomosis. So when these veins get dilated, actually it can come out through the mucosal membrane as polypoid structure. Okay, suppose these veins are dilated and they come as a polypoid structure, polyp-like. And in lithotomy position, they are present generally in 3 o'clock, 7 o'clock and 11 o'clock position. বলো কি বলছো বলো না বলো আমার সাথে একটু কথা বলো তুমি এটা কি বলছিলে বন্ধুকে বলো না আর ওটা কি বলে বলো বলো কি বুঝলে সেটাই বলো বলো কি বুঝলে হাসতে হাসতেই বলো আমি হাসতে হাসতে শুনবো না না আমি হাসতে হাসতে শুনবো আমি হেসেই যাবো তুমি হাসছো আমি হাসি হেসে হেসে শুনি হাসি হেসে হেসে শুনি শোনো বলো বলো কি হেসে হেসে কি বলছিলে বলো বলো উত্তর দাও হেসে 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 বোকা বোকা হাসছো গেল ক্লাসে কিছুই বুঝতে পারছো না করে হাসে বোকা 3 বার হাসে কিন্তু একবার না বুঝে হাসে বা যখন সবাই হাসছে তখন একবার হাসে তারপরে যখন বুঝতে পারে তখন আরেকবার হাসে আরে এমনি এমনি হাসছো কেন তাহলে so there are development of some polypoid structure actually the veins actually get dilated and they comes out through the lumen and they are present. The positions are at 3 o'clock, 7 o'clock and 11 o'clock in lithotomy position. Lithotomy position you will know gradually in gynecological procedure. We put a patient, and also in dissection of the perineum we put the cadaver in a lithotomy position. Okay, we fold the knee, we fold the hip, and the leg is being put and over there are some holding material and it is being placed, and that is called the lithotomy position. And lithotomy position, the 3 o'clock and 7 o'clock and 11 o'clock position, we get the primary piles. These polypoid structures are called the piles. Okay, and sometimes we can get the piles in other positions. They are called the secondary piles. Now about the nerve supply. It is sympathetic. We know it is definitely coming from the there is a celiac, within the abdomen there are three plexuses. Celiac plexus, superior mesenteric plexus and inferior mesenteric plexus. They are present around the celiac artery, and the one is around the superior mesenteric artery and around the inferior mesenteric artery. They are actually coming from the thoracic splanchnic nerve, and so inferior mesenteric plexus actually supplies the rectum and anal canal. Okay, rectum and a part of the anal canal, not the whole. And the parasympathetic is coming from the pelvic splanchnic nerve. Already I have told you that is from the S2, S3 and S4 segment of the spinal cord. Okay. Already you can see it here, that is the S2, the pelvic splanchnic nerves. Splanchnic nerve you have already seen in the thorax. Greater splanchnic nerve, lesser splanchnic nerves and least splanchnic nerve. In the posterior thoracic wall you have seen. Taito, dekhacho to. Similarly, it is present in the in the pelvic region. This is the picture of the lymphatics. From upper part you can see, okay, rectum is divided into upper part, middle part and lower part. From upper part it is going to the pararectal nodes, and also from the middle part you can see these are the internal iliac group of lymph nodes. Okay, from here it can go ultimately the draining channel is the inferior mesenteric node. From here around the abdominal aorta, pre and para-aortic lymph nodes, and ultimately intercisternar chyli. And from the lower part, okay, this is the important part. There is in the anal canal, this line is called the dentate line. Above the dentate line, it will go to the internal iliac nodes, and below the dentate line, it will enter into the inguinal lymph nodes. Dentate line is called the watershed line, because you have seen the watershed. In a heart, you can see there is a watershed is there. Water is flowing on one side, and from here it flows in other side. So that point is called the watershed line. Similarly, this dentate line of the anal canal is, you are thinking it might be due to any sepsis or local pus formation or anything. Always keep it in mind. The lower part of the anal canal, rectum and anal canal, from here lymphatics actually drains into the superficial inguinal lymph node. Why? In case of any anorectal carcinoma, it is not very uncommon. Colon cancers are not very uncommon. Anorectal cancers, carcinomas, they are not very uncommon. So from the lower part of the anal canal, it can drain into the superficial inguinal lymph node. So if a patient comes to you, always have a suspicion whether it is not coming from anal canal or not. Okay, so this is very important. Otherwise, if you miss it, we can actually suffer from CPA, Consumer Protection Act. It is always hanging over us. All the people who are doing private practices, okay, we are under this. That means Consumer Protection Act. So at any point of time, if we miss anything, we are very much answerable to the courts of law. So knowledge of anatomy in this regard is very important. Now about the anal canal. Chalo. This is a parectal examination. Okay. Kothay gelo? Anal canal. Anal canal has 3 parts. So from where it is continued? Rectum is continued as anal canal. From the perineal curvature, ½ inch below and 1 inch in front of the tip of the coccyx. It is continued as the anal canal. The length is 38 millimeter or 3.8 millimeters. Okay. So direction, it is directed downwards and backwards and ultimately opens at the anal orifices. Chobi, ये सब देखिए कोई लाभ नहीं. Tip of the coccyx. Now, this anal canal, you can see the interior of the anal canal. If we cut the anal canal, we can see there are 3 regions. This is the first region. This is the junction between the rectum and the anal canal. And from here up to 15 millimeters, okay, this area, here we can find there are some anal folds, the mucosal folds, longitudinal mucosal folds. They are called anal columns. Then which ends in a valve. Okay, these anal columns, they end in a valve. Okay, these valves are called anal valves. And in between this anal column and the valve, we get some pockets which are called anal sinuses. So they are called anal columns of Morgagni, anal valves of Morgagni, and anal sinuses of Morgagni. And here, this part, and this part is called the dentate line or the pectinate line. Area above this pectinate line, it belongs to autonomic nervous system. Autonomic nervous system. And area below this area, below the pectinate line or dentate line, that means this area or this area, next 15 millimeter and next 8 millimeter, this belongs to somatic system. The somatic nerves will supply here. Somatic means which is in our control. Okay. Why? The part above this area, it develops from endodermal cloaca. We know the gut tube develops from the endoderm. There is the endodermal gut tube. Okay. So that part belongs to the endodermal gut tube. And whereas this part actually originates from ectoderm. Ectoderm. So there is a junction between endoderm and ectoderm at the pectinate line. So again this pectinate line is called the watershed line because above the area above the pectinate line belongs to endodermal area. It develops from endoderm and area below this pectinate line develops from ectoderm. Ectoderm. So there is a connection between ectoderm and endodermal cloaca. First, there remains a And so the nerve supply differs, because for the endoderm it is the autonomic nervous system, and for the ectoderm it is the somatic system. Again, the lymphatics above the pectinate line, it drains into the internal iliac group of lymph nodes. From below area, it goes to the inguinal group of lymph nodes. So the next area is called the area pectin, and it is lined by, and histologically the area above the pectinate line is different. It is been lined by the skin. What we get? Stratified squamous epithelium and keratinized epithelium and sebaceous gland, hairs, all these structures we find. So in last 8 millimeter, this area is called the anal verge. Mucous membrane, we can get some venous plexus, and this venous plexus gives a bluish coloration, blue. So it is called area pectin. And below this area we can get the skin, so that is pigmented area where we can get sebaceous gland, hairs, and here we can get the skin folds, which is called the corrugator ani QT. Okay. Now, what is the importance of this line? One is embryologically this belongs to endoderm, this belongs to ectoderm. Second, lymphatics is different, it is going towards the internal iliac group of lymph nodes, and from here it is going to the superficial inguinal lymph nodes. Arterial supply from here, it is actually by the superior rectal artery, and from this area inferior rectal artery and middle rectal artery. Venous drainage, from here we are superior rectal vein, from here middle and inferior rectal vein, that means systemic veins. Nerves different, lymphatics different. So this dented line is called watershed line. Why dented line is called watershed line? Because nerve supply is different. From here there is divergence of nerve supply, divergence of lymphatic supply, divergence of the arterial supply, divergence of the venous, divergence of the development. There is one tube which is called endodermal tube, and there is one tube that is the ectodermal cloaca. They get fused with each other like these two. One is endodermal tube and ectodermal tube. There is a connection. First there is one membrane in between, and gradually this membrane gets dissolved and there is a communication. And if the membrane is not dissolved, what will happen? Imperforate anus. This is ectoderm, this is endoderm. There is connection. Okay. There is a communication. There is a membrane which separates, which gets dissolved, and ultimately there is a connection. Okay. So in case of child, which we might find he or she cannot pass the stool, we can suspect the imperforate anus. So we have to dissolve that membrane. Okay, this is clinical anatomy. And already I have come across with the piles. Next is the fissure. When this anal, suppose a hard constipated person is passing a hard stool, what will happen? These anal valves will get affected. The tearing of the anal valves, which is called anal fissure. When those valves are gets opened or there is tearing of this valve, it is called anal fissure. Very, very painful. Anal fissure is very, very painful. And another thing may happen, suppose there is a sinus develops and there is a communication from here and ultimately there is a communication outside, that is the skin. If there is a pus formation here and it may enter and ultimately forms a passage and it can come out through the skin, it is called fistula, anal fistula. Fistula means any passage. Any purulent material may come out through this area. It can create a tract from the anal canal and it can enter. That is called anal fistula. So anal fistula, okay, anal fissure, there are two separate things. What is fissure? When the valves get torn. Okay, and there the patient cannot hold the stool properly. There is again anal incontinence. Okay. So anal fissure, anal fistula, and that is piles or hemorrhoids. They are called hemorrhoids. Hemorrhoids, primary piles, when it is seen in 3 o'clock, 7 o'clock and 11 o'clock. And secondary when it is found in other places. Okay.